Welcome to King Abdullah bin Abdulaziz University Hospital. This is a presentation of the fall prevention and management of patients in KUH. Thanks to the initiative of the EBP team and the Quality Improvement Unit, we have produced a self-study module for the staff nurses of King Abdullah bin Abdulaziz University Hospital. We are here today to discuss to you about the fall prevention management. I am sure that everyone has a knowledge about this topic, and we promise over the entire discussion, you will learn a lot. Before we begin, I want to highlight exactly what we want you to take away from this presentation. Chapter 1, Fall Overview. Chapter 2, Creating a Safe Environment. Chapter 3, Fall Assessment and Management. Chapter 4, Fall Monitoring, Reporting, and Documentation. Remember guys, questions will be entertained after the presentation. Now let's proceed to the objectives of this presentation. Our first objective is to present the best available information for the effectiveness of interventions designed to reduce the incidence of falls in patients during hospitalization. And second, to provide a detailed summary of the characteristics of patients who fall, major hospital that contribute to falls, and interventions that are currently employed or being trialed. We are going to discuss about fall incidence and prevalence and worldwide implications. Remember that falls are a major international public health problems. It is estimated that 424,000 fatal falls occur each year, making this the second leading cause of death from unintentional injury after injuries caused by traffic accidents. Falls are the major cause of injury in older people over 65 years, followed by traffic accidents, burns and fires, drowning and poisoning. Throughout the world, the highest rates of mortality from this cause correspond to persons aged over 60 years. Efforts to prevent or reduce falls and their consequences, which are among the most frequently occurring adverse events in healthcare institutions, have become a priority goal for health organizations concerned with clinical quality and safety worldwide. The importance of this issue is highlighted by the fact that one of its safety standards included by Joint Commission International in its accreditation manual for hospitals is reduce the risk of patient harm resulting from falls. Furthermore, falls rank 6 on the list of JCIA as a sentinel event. Therefore, fall prevention strategies should be comprehensive and complex. Research and public health initiatives should be prioritized to further define the burden, explore variable risk factors, and utilize effective prevention strategies. They should support policies that create safer environments and reduce risk factors, promote engineering to remove potential for falls, train healthcare providers on evidence-based prevention strategies, and increase the education of individuals and communities to build risk awareness. So, what is fall? A fall is defined as a sudden, uncontrolled, unintentional downward movement of the body to the ground or other object. This is according to our KUH APP manual. Now, let's discuss about the types of fall according to our KUH APP fall prevention manual. First, accidental fall. An accidental fall occurs when a patient is oriented but rolls out of bed or trips or slips due to environmental risk factors, or a neonate is dropped by a parent or a caregiver. An assisted fall means that the patient was being assisted when the fall took place. A developmental fall is a non-injurious fall that is common to infants, toddlers learning to walk, pivot, or run. A near fall is when a sudden loss or balance that does not result in any fall or other injury. An anticipated physiological fall is a fall that is attributed to a physiological cause but the occurrence could not be predicted. For example, seizure. And the last one is an unwitnessed fall. In the event when a patient is found on the floor and no one is aware of the said events. Now, we are in our chapter 2, creating a safe environment. 4 important things to consider in fall prevention and management. First, assessment. Second, preventive measures. Third, management. And number 4, documentation. Now we begin to our assessment. First is the fall risk identification, which is composed of identifying intrinsic and extrinsic factors. Fall risk assessment in and out patient. Outpatient fall risk assessments can be done on 2 levels. The primary care provider can do an initial screening, then refer patients that are at risk either physical or occupational therapy to perform a more in-depth balance assessment. If several medications and supplements are listed, have a pharmacist review the medications and supplements for any drug interactions or side effects which could increase the likelihood of falls. Who are at risk? Intrinsic factors or physiologic factors? Patients who are in their advanced age. Patients who are taking medications. Patients who are fear of falling. Patients who have previous falls. Muscle weakness, gait and balance problems, poor vision, postural hypotension, and patients who have chronic conditions including arthritis, diabetes, stroke, Parkinson's, incontinence, and of course, patients who have dementia. Let's proceed to our extrinsic factors, or also known as environmental risk factors. Lack of stairs and handrails, poor stair design, lack of bathroom grab bars, dim lighting or glare, obstacles and tripping hazards, slippery or uneven surfaces, psychoactive medications, improper use of assistive devices, and also patients who are taking medications. When to conduct fall risk assessment? First, on patient admission. Then, any transfer to other unit. And of course, in every change of patient status. All patients receiving care, treatment, and services inpatients and outpatients, including patients waiting in the emergency department for admission, must have a complete fall risk assessment performed by a healthcare provider within 4 hours of admission to establish the level of fall risk. Second, patients who experience a fall during their admissions will automatically be classified as high risk for falls and shall have appropriate prevention intervention implemented. Patients who are completely bedridden will automatically be placed as a low risk for fall and shall have appropriate prevention intervention implemented. Addition referrals shall be initiated to pharmacy and rehabilitation services when the patient meets the following criteria as a part of the risk assessment. First, patient is more than 60 years old. Second, patient takes 2 or more high fall risk medications. Third, patient has a history of falls within the past 6 months. To our rehabilitation services, patient is more than 60 years of age, has a history of falls within the past 6 months, and has a mobility impairment. Now, we're going to tackle on the tools used in fall assessment in King Abdullah bin Abdulaziz University Hospital. The Humpty Dumpty Fall Scale. These are for children aged 3 years old to 18 years old. There are 6 common parameters. First, the age, gender, the diagnosis, cognitive disorders, environmental factors, and response to surgery or sedation and anesthesia. And last will be the medication. For the scoring, each measures are evaluated on a scale of 1 to 4, whereby 12 points or more indicates high risk of falling. 7 to 11 score for low risk, with a maximum score of 23 and a minimum of 7. Moore's Fall Scale Risk Assessment Tool. This is intended for adult patients ranging from 18 years and above. The assessments are: first, focuses interventions on specific areas of risk rather than general risk score. Second, easy to determine if someone is high risk because nearly every risk factor categorizes a patient as high risk. And third, there are only two categories of patients, such as high risk and low risk. Welcome to our Chapter 3 of our Fall Prevention and Management Manual. In this chapter, we are going to discuss about post-fall assessment and management. Preventive measures for staff, patient, and family education. For staff education, effectively trained staff will increase the awareness of individuals at risk of falling, assist in identifying individual and environmental risk factors, and increase the likelihood of preventive strategies being implemented before a fall occurs. The JCI, under its Facility Management and Safety, states that all staff are educated about the facility, how to reduce risk, and how to monitor and to report situations that pose risk. While for SIBAHE, outlined nursing competencies to be assessed include but not limited to the following: patient and family education, providing education on the fall prevention program to individuals and families can be a contributing factor to the program's success. Knowledge that a fall prevention program is in place will convey an organization's attitude of safety and caring for the individual supported. Individual preventive strategies and environmental preventive strategies may be better accepted when individuals and families understand the reason behind them. Information should be provided upon admission and reviewed on a regular basis. Education to patient and family education must include: first, purpose of fall prevention program, members of the fall prevention program team, the fall risk assessments, such as individual or environmental, give an explanation to the patient or family regarding restraints, explain purpose and application of restraints, the alternative use of restraints, the criteria for release of restraints, the plan of care, and the patient's rights. Steps taken after a fall occur. Evaluation process after a fall occur. Preventive strategies for the individual, and how the fall prevention program is evaluated. Environmental safety. In our institution, we have established fall risk reduction environment like all beds in KOH have side rails. Inpatient unit has a built-in grab bar in bathrooms and hallways, and call bells are within patient's reach. Equipment safety. Ensuring that all patient assistive equipment in the unit meets the safety standards and is properly maintained. The machine shall be reported to the overseeing department. Utilizing reasonable, out-of-the-market healthcare devices with reasonable cost and efficiency. Body support for patients like hip protectors, binders, foams that can be used on patient to lessen the effect of unforeseen traumatic injury like from fall, and machine or equipment risk. Restraints. Orders for restraints are renewed every 24 hours. After evaluation by the physician, all patients with restraints require documentation at least every 2 hours, and the patient's family is kept informed for any changes. According to KUH APP, Nursing staff must be committed in limiting the use of restraints to clinically justified situations and only after less restrictive methods have been evaluated and determined to be unsuccessful or inappropriate. Such situations may include the use of restraints must be initiated by individual physician's orders written specifically for the patients concerned. Time limited. 24 hours is the maximum duration per order for an adult patient, and 4 hours for maximum duration per order for pediatric patients. Documented in the patient's medical record in track care or downtime form. The least restrictive type appropriate to the episode shall be used. Use only a type of approved by KUH, and patient shall never be put in restraints as a means of discipline, for staff convenience, or as a way to control behavior without clinical justification. No PRN orders are allowed for restraints. Each restraint episode requires a physician order that indicates the reason for restraint, type of restraint to be used, and the duration for which the restraint may be applied. In emergency situations, a telephone order for restraint use is accepted, but the physician must assess the patient and write an order within 1 hour of the telephone order. An incident report must be completed after application of restraints. Accurate documentation must be completed detailing any restraint restrictive procedures used. Preventive measures for newborn falls. Have a newborn falls policy in place including a no co-sharing or bed sharing policy. Assess the effectiveness of the information provided to parents by regularly asking them during hospitalization about the risk of newborn falls and safety measures. Nursing staff need to be vigilant in their monitoring when newborns are placed in the maternal bed. Make sure the newborn is moved back to the bassinet by the mother, family members in the room, or nursing staff when the mother is preparing for sleep, is becoming drowsy due to medication, or are about to fall asleep. Implement early rounding, checking on mothers and babies. Keep mother's bed in the lowest position. Remove tripping hazards and obstacles in order for the mother to move safely. Provide regular information regarding fall prevention along with co-sleeping and feeding advice. Preventive measures of geriatrics or adult patients. For low-risk patients, if poor balance, to supervised mobility. Orient patients to surroundings. Place call bell and personal belongings within reach. Keep bed in low position. Ensure safe footwear and adequate fit of clothing. Provide nightlight at bedside. Lock wheels on wheelchairs, beds, and night commodes. Use half-length side rails instead of full-length side rails. For high-risk patients, always share information of high-risk patients with colleagues and monitor these patients closely. All staff to observe this group of patients closely. If poor balance or mobility, staff to assist with mobilization at all times. Assess the need for a companion. Poor functional and cognitive ability will impair the inpatient's ability to ambulate safely and therefore check patients every 2 hours at night. Place call bell and personal belongings within reach. Keep bed in low position. Ensure safe footwear and adequate fit of clothing. Provide nightlight at bedside. Lock wheels on wheelchairs, beds, and night commodes. Have bed exit alarms in place. Use half-length side rails instead of full-length side rails. Maintain surveillance of floor and surfaces for fluids. Remove obstacles from passages. Management. Key components of the immediate post-fall assessments include: first, the registered nurse must immediately check if there is a loss of consciousness. If yes, check the patient's airway, breathing, circulation, GCS, and ensure safety of the environment, and call for help or activate code blue as necessary. If no loss of consciousness, you should check for fractures. spinal injuries, soft tissue injuries, cuts and abrasion, head injury. If no signs of fracture, spinal injury, or head injury, perform a quick nursing assessment and follow KUH manual handling guidelines for assisting patients to get up from the floor. If you suspect any injury, it is important not to move the patient and allow the MRP to check the patient first before moving. According to AHRQ, there is increased risk of intracranial hemorrhage in patients with advanced age on anticoagulant or antiplatelet therapy and non-coagulopathy, including those with alcoholism. In addition, there may be late manifestations of head injury after 24 hours. Therefore, the nurse must continue observations at least every 4 hours for 24 hours or as required. Ensure patient is made safe and comfortable. Ensure adequate pain reliever if necessary. Observations must be undertaken and documented in the patient's records to include patient's at-risk score, oxygen saturation rate, blood sugar if patient is diabetic, postural BP if possible, the Glasgow Coma Scale, and the most responsible physician must be fully informed of the findings of the nurse's clinical assessment following the fall and must be made aware that a post-fall medical assessment should take place within 24 hours and must decide how soon they should attend within the time scale dependent on the nurse findings. Always notify the family of the patient about the fall incident and document in the nurse's notes. Close observation and monitoring following a fall is a critical factor of the post-fall management care plan, as the patient may develop symptoms at a later time that can indicate serious changes in their condition, especially those who are badly injured and those with presenting comorbidities. Identifying what contributed to the fall will help the healthcare team to develop an individualized care plan to provide the necessary age-specific intervention based on the client's specific needs and status, and eliminate those factors in order to prevent secondary event of fall. Interdisciplinary team must carefully review, determine, and communicate any pertinent information about the fall. Chapter 4. Fall Monitoring, Reporting, and Documentation. 4 essential components needed to be done in the post-fall management. Post-fall huddle. Transparent reporting. Trending and analysis of fails, which can inform improvement efforts. Reassessment of the patient. Essential components are a brief staff gathering, interdisciplinary when possible, that immediately follows a fall event, convenes within 15 minutes of the fall event, clinicians responsible per patient or resident during fall event, involves the patient or resident whenever possible, in the environment where the patient or resident fell leads to post-fall huddle. Steps to the post-fall huddle. Team leader makes an announcement. Convene within 15 minutes with the patient in the environment where the patient fell. Conduct analysis and determine types of fall. Team leader summarizes information gleaned from post-fall huddle, and interventions for prevention of repeat fall are decided by the huddle team. Team leader completes of the post-fall huddle form and processes the form according to medical center policy and procedure. Modifies the fall prevention plan of care to include intervention to prevent repeat fall. Communicate updated plan of care in patient hand-off reports. Complete post-fall huddle form. After the post-fall huddle, the nurse manager should follow up with staff to ensure interventions are implemented, and with the patient to make sure the patient understands the interventions being implemented to prevent a repeat fall from occurring. This follow-up process engages the patient as a partner in the fall prevention strategies. The nurse manager can also answer any questions or concerns voiced by patient or family. Reporting. If patient falls despite the best measures implemented, proper documentation and reporting must be implemented in order to communicate fall incident to other healthcare staff, and necessary preventive measures will be implemented. Nurses must be familiar on what forms to accomplish in documenting the fall incident. Document fall in nurse record. The details should include the mechanisms of fall, such as slip, trip, overbalance, dizziness, location, time, and circumstances of fall, evidence of injury, any loss of consciousness, relevant environmental information, what fall risk strategies were in place at the time of fall and actions taken. They must also comply the post-fall assessment tool, complete the post-fall huddle form, and incident report. Fall reporting system. According to KOH APP manual, incident reporting system, incident reports shall be completed by the person observing, involved in, discovering, or by someone who becomes aware of the facts related to an unreported incident. Incident report must be completed and reported within 24 hours and no more than 72 hours. The incidents reporting system is used by the Patient Safety and Risk Management team of QI and Patient Safety Department as a mean to identify trends, potential risks, and potential improvements as part of the organization for performance improvement programs. The purpose of an incident report is to document the exact detail of an accident or unusual incident that occurred in a healthcare institution. This will be used in the future when dealing with liability issues originating from the incident. This is also to protect the nursing staff against unjust accusation, to protect and safeguard the client in case of negligence on the part of the nurse, helps in the evaluation of nursing care to ensure safe care to all patients. Analysis of fall. Evaluating and understanding the problems that contributed to committing error outcomes is best done by conducting root cause analysis. The main goal of the root cause analysis process is to find out what happened, why it happened, and how to prevent it from happening again, as they capture both the big picture perspective and the details. Root cause analysis should be performed as soon as possible after the error or variance occurs. The last part of this lecture is about post-fall patient reassessment. Reassessment may include a review of a wide range of contributing factors, including medications, behavior, or functional change like gait, consciousness, neurologic function, skin integrity, or vital signs to rule out possible injury. This is the end of Chapter 4. The post-fall patient reassessment and management algorithms will be discussed further by the QI Fall team. This is your chance to ask questions and provide feedbacks in regards with the lecture. Thank you for listening and cooperating. And thank you for being a member of a zero fall incident in King Abdullah bin Abdulaziz University Hospital.